let me start from the beginning. So welcome to our live IVF webinar tonight. And well, I'm happy to be here. We apologize for being late, but as you know, there were some technical issues, but we are now back. And we will start off with Dr. Gianaroli's presentation. And before that, I just want to remind everyone that this event also has been brought to us thanks to our partners and ambassadors as well. You can see them right here. And tonight we have another very important topic to tackle. And this time it's personalization of art treatment. And with us, you already know, is Dr. Luca Gianaroli from Reproductive Medicine Institute, which is located in Bologna in Italy. And he will start off with his presentation. And after that, it will be your time for your questions. Remember, you can type them in the chat section. And well, then he will be happy to answer all of those. That will be it from me. Dr. Gianaroli, and you're ready to go ahead with your...
Okay, so good evening. Well, we will never know why the system didn't work. The only variable compared to all the other webinars that you had is the Italian speaker, so maybe that's the problem. So, okay. Personalization of ART treatments is something that looks peculiar, but actually should be routine, like it is in every branch of medicine. I don't think that none of us as a GP that give us the same amount of antibiotics if we have one disease or another, or if we weigh 100 kilos like me, or 60 kilos like somebody else. Well, despite of all this, ART treatment has a tendency to be done in a routine way, not in a personalized way. So the thing that I would like, the few things that I would like to share with you tonight are a few concepts that are really related to personalization of ART treatments. First of all, ART is not the only treatment for infertile couples. I like to remind you that a part of restoring spontaneous fertility and recommend some expectant management if there is a possibility to do so, the most important thing is to choose the best treatment option available in terms of invasiveness, effectiveness, risk, and also cost. We should also think about the possibility to discourage access to treatment in case of high likelihood of negative outcome. This is something that, of course, has to be discussed with the couples, but we have to bear in mind that not necessary because a treatment is required, a treatment can be done in an efficient way. So if we take into consideration all these pillars, the criteria for personalization of an ART treatment should consider at least the age of the female partner, the duration of infertility, and all the multiple infertility factors that are really more related to the medical history of the couple. I'm not saying of the patient, I'm saying of the couple, because both partners can contribute to the success or to non-success of the treatments. I don't want to go through the factors that are causing infertility in details because I don't think that we have time to do so. But I'd like to remind you that if we want to know if there is a factor that is causing infertility, we cannot skip some diagnostic procedure because we will never be able to make a diagnosis of genetic factors or congenital factors if we don't do some specific exams. Then we have the acquired factors, and as I was mentioning before, the age of the female partner. That is one of the factors. So the factor causing infertility that I was just mentioning to you are the cause of the success or the cause of non-success. And if we are not able to make a proper diagnosis, the risk is to standardize the program and the protocols, avoiding what we are here for tonight. So avoiding the concept of personalization of the treatment. Only a few words on saying that we can skip some of the genetic factors using some solution, and you are, I'm sure, aware of this, there are some cons for all the solutions that we are taking into consideration. For instance, if you have genetic factors that we want to substitute one or two of the gametes, we should remind that there are some cons in gamete donation, like in some countries they are not allowed. It's not the case of UK. The same for surrogacy. While if we try to select or deselect those embryos that are not suitable for transfer, both because they do not implant or because they can bring to an early miscarriage or because they can carry some genetic abnormalities, again, a part of reconsidering the concept that not in all countries they are allowed. They are not, PGT is not allowed or is not at least applicable to all the disease, and that the new techniques that are currently developed, they are changing the scenario every day, but not necessarily they are making it better. If we look at the congenital factors of infertility, we should also take into consideration some factors that sometimes people disregard as a congenital problem. For instance, we know the role of endometriosis and that the role of fibromas of the uterus, they can also be linked to congenital factors, as well as for the male partner, varicocele. So apart of those that are quite clear as a problematic topic coming from congenital factor like agenesis or cryptopsides or uterine malformation, also this, just as an example, should be considered as a congenital factors or factors that could be altered by the congenital situation. Which are the solution for the congenital factors? So are we ready to, or are we prepared to personalize the treatment? Well, for some factors, ART are not really indicated, but we need to look into reproductive surgery. That has, of course, like some cons, like positive outcome that is not guaranteed. And not always even surgery is applicable. It depends on the pathology. ART, of course, could be a solution once some of the congenital factors are solved, as far as we take into consideration that not always we have the same percentage of positive results. I understand that this is an extremely busy slide, but I like to give an example of what we mean for personalized medicine. So let's say that we have done the diagnosis and we have a tubal problem or an hydrosalpinx or a tubal block. We have a patient with that has a multifollicular ovarian pattern, or a PCO patient, or a patient that has problem in the ovaries related to non-malignant disorders, or patients with endometriosis. For these different diagnoses, we need to act differently. If we have a tubal pathology or an hydrosalpinx, the first thing that we need to do is to check if there is a tubal patency after a test that has been done. Why we need to do so? Because it depends where the block is. We should also have, before ART, the removal, so a surgical intervention to remove the tubes. Once the tubes are removed, so we can skip the risk to reduce the possibility of success of ART because of the toxic fluid generated by the pathological tubes. So once we have removed the tubes, then we can go to a conventional IVF or an ICSI. But once again, I think that we should at least consider the age of the patient, because we will go back to this. If the patient is less than 37 years old and she has normal period, she can enter a program that we call IVF LITE. So it's a very simple regime of stimulation, and it doesn't matter if the transfer is done fresh or frozen. The total amount of deliveries, once that the patients are exposed to 3 embryo transfer, cannot be below 70%. So in other words, 70% of the patients that enter this treatment will deliver it. If they do not get pregnant and they do not deliver it, but they have a miscarriage or an abortion, most probably, as far as also they do not get pregnant at all during these 3 attempts, they should move, because there must be a reason why they didn't get pregnant. So they should move directly to pre-implantation genetic testing for aneuploidy, because most of the time, this 30% of patients that are considered easy patients to deliver, they didn't do in 3 attempts, they most probably have some problem related to the gametes. So PGT should be recommended. If we are going for a patient over 37, again, if she gets pregnant, fine. If she delivers, fine. But even if you're using very complex and personalized induction of ovulation treatment, if the pregnancy does not occur, or if a miscarriage occurs, again, this couple should be addressed to PGT for aneuploidy. I'll go back to PGT for aneuploidy later on. If you have patients that have multiple follicular ovarian patterns, so they have the tendency to respond very well, extremely well, or even worse, if they are clearly diagnosed as PCO patients, we can go for a routine IVF, but what we need is to freeze all. They should not be exposed to an embryo transfer fresh, because the risk of hyperstimulation is too high, because the endometrium most probably is not the best endometrium, and because not necessarily these embryos are the best embryos that they could have, since when they have multifollicular patterns or when they are PCO patients, the tendency to produce a high number of ovocytes, but among them having a high percentage of chromosomally abnormal eggs, is most of the time a reality. So again, freeze all the embryos. And then when we thaw them, it doesn't matter whether they have been frozen, but they should go to a culture system that allows these embryos to reach the blastocyst stage. This only with the aim, at least, to check that these gametes and these embryos are able to reach the pre-implantation stage. Once again, because this pathology, independently of the age of the patients, produce a large amount of ovocytes, but the percentage that I was mentioning before of chromosomally abnormal ovocyte is high. And then again, once that we do our frozen embryo transfer, we can get them pregnant or non-pregnant. If they are pregnant, they deliver, it's okay. If they have a miscarriage, we should use these remaining embryos with the system of PGT for aneuploidy. Same story if the patients, once they got a transfer, but there is no pregnancy, despite the embryo transfer has been done, again, this should be checked for aneuploidy. If the patient don't get pregnant because the quality of the embryo is very poor, so there was no embryo transfer, then the recommendation is to look, once that the problem has been identified in the poor quality of the embryo, mainly due to the poor quality of the ovocytes, for an ovocyte donation program. And I will go back to this again. So if we go for PGT for aneuploidy, again, no problem if we get our pregnancy and our delivery. But if we have a miscarriage, then we have to think about that there is something that doesn't work despite the check of aneuploidy has been done. So there are more subtle problems that could not lead to a full pregnancy. So maybe we could have an indication, also in this case, for an oocyte donation. If we don't get pregnancy after PGT for aneuploidy testing, things are different if we had an embryo transfer, because then we can give to this couple another chance with the same system. But if an embryo transfer has not been done because there are no chromosomally normal embryos available, once again, we should consider the concept of oocyte donation. If we have patients with non-malignant ovarian disorders, again, most of the time we should think very deeply to the concept of surgery to remove the pathology. And then once that we do so, we have to assess the ovarian reserve using two simple tests that I am sure that all of you know. And that is the same when patient having endometriosis. So if after the oocyte reserve test, they look normal in terms of oocyte reserve, they can enter the normal, the usual protocol here. If there are poor responders, once again, the system in terms of induction of ovulation and protocol should be deeply personalized. If we reach the point for which oocyte donation is needed, again, of course, no problem if we have a pregnancy and a delivery, but we should pay a lot of attention if after an oocyte donation we have a miscarriage. We have to consider in this case also the gamete, the male gamete, as a problem that could have generated this miscarriage. So a FISH test on sperm should be done. And we have to be careful if after few treatment of oocyte donation there is no pregnancy, because once again, if there is no pregnancy but embryo transfer has occurred, as I was mentioning before, 1 or 2 treatment more can be done. But if there is no pregnancy because embryos did not develop and we didn't reach the stage of embryo transfer, we should investigate once again the male gamete. So as you can see, even only starting without taking too much into consideration the age of the parent, just starting with 5 diagnoses, we can have completely different and completely personalized protocol. So each patient or each couple should be first enter ART once the diagnosis is properly done. I think that there is a lot that couples can do to increase their chance of success as far as they by themselves are able to personalize their lifestyle, avoiding some environmental factor and look very close to the factors related to the diet, because they are part of the acquired factors. And when we talk about acquired factors of infertility, most of the time we think to the usual things that are clinically evident: some contraceptive, medical treatment, anti-cancer therapy, surgery, STDs, and so on. And we take very little attention about these three, that actually they play an important role in terms of success. Again, just to give you an idea of what can be done to personalize the treatment, if you look to this list that is not probably fully comprehensive in terms of lifestyle, and you go down to here, and then we look at the environmental factors, and then we look to the dietary factors, we see how many things we could reduce or avoid to personalize our fertility rate, or the fertility rate of the couple, even before and also during treatments in which ART play, of course, the major role. To finish, I just want to show you something that is very technical, but I think that many of you have already seen this. So this is the number of primordial follicles according to the age, starting when the female individual is still in the womb of the mother, and according to the age, how many follicles, primordial follicles that are written here, are present. There are 2 considerations to do. One is very well known to all of us, and I think to all of you, that the number of follicles is dramatically declining with the age of the patient. But what is even more important, if you can have a sort of helicopter view on these slides, you can see that the range, the variability with the same age is enormous, and it varies patient to patient. So we shouldn't be worried that at 38-year-old we have a lower chance compared to a 35 years old without having assessed first the ovarian reserve, because you could have a very poor ovarian reserve with a very limited number of follicles in this age that will give us less chance, most probably, that a patient with 2 or 3 more years that have a much higher ovarian reserve. So taking into consideration that infertility and aging, is true that they are correlated, but if we want to personalize the treatment, we should look at this figure and keep this in mind, that all of us do react differently to treatments according to what we have in this specific case in terms of number of follicles and primordial follicles. In fact, what we do if we have a patient over 40, just again, another big category of patients, is a big slice of patients, at least in Italy. Well, the first thing that should be done if we want to personalize the whole process is, in a very simple way, assess the ovarian reserve plus hysteroscopy to be sure that the uterus is the right place to put the right embryos. If you have a normal ovarian reserve, then we can have standard protocols. It doesn't matter if the age of the patient is 40. And again, here you are used because of the previous slide. We can have a pregnancy, a delivery, but we can also have a lucky miscarriage. And in this case, PGT for aneuploidy should be done. If there is no pregnancy, and that is due to the fact that there was no transfer, this has to be discussed deeply with the couple. If transfer has been done, we can do again the cycle more than one time, or maybe recommending later on PGT for aneuploidy. If you have a low ovarian reserve, then here we have to be much more careful. Again, after first standard treatment, pregnancy and delivery is fine, but miscarriage, due to the age of the patient, should immediately recommend to send the patient to a PGT program or even to an oocyte donation program. If no operation has occurred but transfer has been done, fine to repeat. While if no pregnancy has occurred because no embryo transfer, we need a special personalization of the treatment with a protocol that we call priming protocols, where the ovary is forced to produce not only a little bit more oocytes, but also better oocytes. Again, you now are familiar with pregnancy and delivery, but if miscarriage occurs, this program should be abandoned and the patient should be recommended for oocyte donation. If no pregnancy occurs, again, if transfer is done, we can repeat the work, or we can send the patient to oocyte donation. And again, for PGT for aneuploidy, you can be successful or not, and if you are not, again, oocyte donation could be the last option. So the last point I'd like to make in terms of personalization is to think about banking the oocytes. Social freezing could be considered as a sort of fertility preservation, can, apart of being recommended for medical reason, can also be extremely useful, even if the patient later on do not require these oocytes anymore, because donation of these oocytes can only be done under different forms according to the national rules. Few words on what I was mentioning to you before closing, and I'm talking about the so-called IVF LITE. IVF LITE is a special program where we enroll patients that have simple criteria, that are naive patients, so no previous ART treatment, regular cycles, younger than 38, body BMI lower than 25, no severe male factor, so no azoospermia, no previous surgery of endometriosis, normal or high AMH value. It works in a very simple way. There is a fixed regime of stimulation, only 1 or 2 ultrasound checkpoint, and we only use from between 3 and 6 ovocytes to reach the stage of having 1, 2, maximum 3 embryos. And we transfer only 1 embryo most of the time, per time. Doesn't matter if it's frozen or if it's fresh. I want only to give you a rough data before going to the final slide showing the use of extensive IVF LITE protocol. So you see the patients that have been enrolled in this study, they were very young, all of them. Not all of them were really able to enter the protocol. So a certain number of them have been discharged from the protocol. So we had 358 couples that ended the program. The end of the program was either pregnancy, either 3 embryo transfer as a maximum. Doesn't matter if they were fresh or frozen. So these 358 couples had 677 oocyte recovery. You see the number of oocytes in general, despite of the age, is quite small, and they end up in 800 transfer. So some of them have done 1 transfer, some of them have done 2, some of them have done 3. The number of full-term pregnancies, so that means deliveries, compared to the number of couples that started the program and they fulfilled the criteria, it was 235. That means 66% of the patients delivered during the program. And you can see here the delivery rate, first cycle, all of them come back. There was no dropout. And then I can explain you why we were able to avoid completely the dropout. All the remaining patients come back, and few other full-term pregnancy occurred. The remaining that didn't get pregnant or that had the miscarriage, they come back, and again you end up with this 66% of delivery in this program. I like to conclude in saying that personalization is dramatically important also in the era of COVID-19. And I'd like to share with you what it has been accepted by the National Society of Gynecology in Italy, but also by the European Society of Human Reproduction. Starting from last week, we resumed the treatment, having in mind that our patients could actually enter only one of these 3 scenarios. Patients that are asymptomatic from COVID-19 with an asymptomatic partner, so the triage is negative, patient or the partner with mild or non-specific symptoms, so potentially positive triage, and patient and or partner with a specific symptom and previous positive test, so a triage positive. So how do we, again, personalize the treatment? In the pre-treatment, so the months before the treatment, if the patient belongs to scenario 1 after the triage, we check the triage again during treatment. If it's negative again, they go with the standard procedure to oocyte retrieval, embryo transfer, or even with embryo transfer if it's needed. If patient belongs to scenario 1 during the pre-treatment, so it's all negative, but during the treatment, one of the 2 partners shows some symptom, then instead of doing the swab, we just do immunoglobulin M or G. And if they are negative, or if only G is positive, the patients or the couple will follow oocyte retrieval in normal standard procedure and embryo transfer if it's needed. We postpone the treatment if during the triage of the treatment, so during induction of ovulation, we suspect via immunoglobulin that something is going wrong, or the patient is going to develop symptoms, or they have already symptoms. If during the months preceding the induction of ovulation, we already have symptoms and we already can have results from IgG and IgM in a rapid way, again, if IgG and IgM sound to us to be safe and negative, we start the induction of ovulation, but during the monitoring, we do repeat the same exam. So the triage is done 2 times, and then if it's negative, they can go to oocyte recovery and embryo transfer. But if the second step shows us that immunoglobulin are showing a risk related to COVID-19, we postpone the treatment. And we also do postpone the treatment if in the first step, so the months before the treatment will start, we found immunoglobulin that could give the risk to the patient to be affected by COVID. So we postpone the treatment. If the couple belongs to scenario 3, we don't start the treatment. It doesn't matter how that she feels. We just postpone the treatment itself. So I just finish here saying that these are only a few examples how you can personalize the treatment, and most probably the majority of the patients need a personalized treatment, and less, more technology advanced, the patients should be enrolled in routine activities. If we do not want to have high risk of unsuccessful treatments. I'm here. Maybe it was a little bit too long. We started too late, probably. I'm here to answer questions if there are.
Perfect. Thank you so much for your presentation and all the details. And yes, it is time for our Q&A session right now. So let's go ahead with the questions. We do have some questions ready. So yes, we were a bit late, of course, but now all is working. So let's not waste time and just get to the questions. Okay, and the first question is right here. My AMH is 1.7 and I had 5 failures with own egg IVF. Each cycle I made not more than 5 oocytes, and 1 egg retrieval it was 7, but non-fertilized. Is this normal, or could it be something wrong with my protocols?
Okay, well, here we are missing 2 pieces of information. One is the age of the patient, and the second one is the quality of the sperm. In this case, it doesn't matter if the husband, okay, good, 38, very good. So considering that we should not expect any problem related to the sperm, at this point, we have to suspect that the problem is related definitely to the quality of the oocytes. And if you are telling me that in 35 oocytes that have been inseminated, plus or minus, there was none fertilized, and if, as I can suppose, was not always the same sperm used, I suspect that you should directly go to gamete donation. I don't think that anybody can help you apart of making a more refined diagnosis. Your eggs, once they are collected, before ICSI is done, should have their polar body removal, the first and then the second, and you can make an analysis of that. And you will have most probably the confirmation that the majority of your oocytes are not suitable to start or to begin a pregnancy. This can also be confirmed if you are looking for babies since a long time, and if your tubes are open, so you have already done insemination. So most probably you don't have an idiopathic infertility. You have an infertility due to the quality of your gametes.
Perfect. Thank you so much for this question and your advice, your recommendation on that as well. Next question is up right here. Is there any possibility for PCOS patients to have a successful fresh transfer?
Yes, but it's limited. It's so limited that I don't think that when you balance the risk of an hyperstimulation and the disadvantage of a poor percentage of results, you should aim to have a fresh embryo transfer.
Excellent. Thank you so much again for that. There is another question here. So my AMH is 52, 82 PMO. I have PCOS and my weight around 90 kilograms. What optimal starting dose of medication?
It would be nice to know which one is your BMI or how tall you are, considering that 52 picomoles roughly means around 8 or 7. Okay, it's 32, so it's very high BMI. Okay, I'm not the right person to tell you that you should lose weight, because if you, well, you don't see me, but I am one of those Italians that has a very high BMI. So considering that the recommendation to lose weight is not the right one, my suggestion is to start very slowly, so with a very low dosage of gonadotropins, could be around 100, 150, and then keep going with the aim of deselecting follicles. So I only have few follicles that can grow, maybe adding a little bit of LH during the stimulation.
Okay, thank you so much again for that. Okay, there's another question, very short one. Do you treat patients from the UK?
Yes, yes. As far as they are happy to travel and to have not only infertility treatment done, but also some good pasta, yes, why not?
Excellent, thank you so much. And let me go to the next question. How is hysteroscopy different from colposcopy? If I had colposcopy done, does it make sense to do the other one, case of unexplained infertility?
Yes, they are completely different exams. Colposcopy give you all the information regarding the cervix, so the neck of the uterus, while hysteroscopy it's get a small optic fibers inside the cavity and can check the normality of the cavity. You can do a very elegant and sophisticated 3D ultrasound, and 3D ultrasound, if it's well done, mainly by expert people, by expert gynecologists, can give you really a lot of information. But if you really want to know if you have small adhesions, if you had a miscarriage before, if you have a termination of pregnancy before, if you have had irregular cycles with some bleeding, if you had curettage before, I mean, if you really want to be sure that the cavity of your uterus is completely normal, you have to do this exam. It's an outpatient exam. Is generally speaking, is not very painful. It has to be done only once, and we give to the gynecologist also the idea where properly transfer the embryos at the right time. So two completely different tests with two different aims.
Okay, thank you so much again for your explanation to this question. And another one is right here. Is there possible successful pressure transfer if trigger of decapital has been applied?
This is a very good question. There are a few data in literature showing that you can have success, but in a reduced percentage of times compared to when trigger is done with ACG. So the recommendation, once again, is not to transfer when decapeptyl is used. What I would like to express, I mean, taking the opportunity from this question is very simple. It took ages to clinicians to understand, and now I think it's extremely important that also patients follow the same concept. Stop thinking about success rate for embryo transfer. Once that you define success rate as delivery or as a clinical pregnancy, it doesn't matter. Then it's up to you. You have to think about the concept not for embryo transfer, but for number of attempts that you want to do. Let's put it in this way. You are 30 years old, easy patients, normal cycles, normal spermic, only some fallopian tube problem. Okay, in our center, and maybe in many others, they are doing even better. If you want to have the chance to delivery 80%, so 10 patients come in and 8 delivery, you have to enter into the concept that we need to expose you 4 times to an embryo transfer. So it doesn't matter then if you get pregnant at the beginning or at the end. But if you want 80% of chance with that age, with that body mass index, with that partner sperm, you need to be exposed 4 times to our procedure. If you want to have your 80%, but you are 40 years old and you have a poor sperm quality partner and whatsoever, to have the 80%, you need to be exposed to 20-25 embryo transfer. Are you able to do so? Do you have the capability to do so? Probably not. Probably you must take into consideration that you can try to get your 50% of delivery rate at the age of 50, as the age of 40. Fine. To get 50% of chance to delivery, we need to do with you 10 embryo transfer. Are you able to help us and are you able to spend your energies, your time, and sometimes also your money if you are not doing this in an NIH system? That is the answer. So first of all, design with your clinician what you really want in terms of percentage of delivery, and then personalized medicine and personalized ART should prepare with you a personalized program inside which you will have the percentage of success rate that have been discussed in advance.
Excellent. Thank you so much again for your advice. Now we have like 2 parts of the question. Okay, I will start with the first one. I'm nearly 40 and had 1 tube removed. I have used 2 different sperm donors. My AMH is 8.28, AFC is 8, X retrieved has been 3 to 5 and fertilized with ICSI, but do not reach to blastocyst. And another part, should I try again with my own eggs? If not, I would use donor embryo. Is there an embryo waiting list? And is this possible for a single lady? Is it anonymous?
Okay, if you are talking about the situation in Italy, first of all, from the clinical point of view, yes, I think that if you are prepared, the best thing is to have an embryo donation. If you talk about Italy, Italy does not allow, so the only restriction of the Italian law at the moment is surrogacy and the treatment of individuals that are not in a stable relationship, so they are not belonging to a couple or they are not married. So in this case, this treatment cannot be done in our country at the moment.
Okay, thank you again for explaining this to us. Okay, and next question is up right here. After many fed transfers, my partner doesn't want to continue IVF anymore for financial and emotional reasons. We agreed to do last one, and therefore I want to make sure I did everything to succeed. It's egg donation plus donor sperm. I'm 38. I will do hysteroscopy and ERA test, PGD, immunoglobulins. And now this very last chance, I'm very tempted to ask the doctor to transfer 3 embryos. However, I know the risk, and this scares me to miscarriage. Should I choose 2 or 3? What is your advice, knowing that there will not be more chances?
No, 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 and no. Don't transfer 3 embryos. Not at all. Convince your husband if there are extra frozen embryos and if it's possible, to keep the extra embryo for the last attempt. Don't transfer 3 embryos, not at all. First. Second thing, ERA test can be a good concept for you. Don't forget that only 3 to 5% of the patients that do ERA test, ERA is finding something, but I think that it's worthwhile to do. PGT for aneuploidy makes sense, even if we are expecting a very limited number of aneuploidy due to the fact that you are using donor gametes. And what I would recommend you, and you are right, to check carefully your uterus. So I think that hysteroscopy, if it's not been done, should be done before you do the last attempt. Don't get tempted to transfer 3 embryos, also because if those embryos are viable, but for any reason you are transferring in the wrong uterus, that means in the wrong month, you are wasting the three of them, while you could have, on the other hand, another chance. On the other hand, if the 3 embryos are good and your uterus is perfectly synchronized, you take a terrible risk to have triplets with all the disasters that could follow a triplet pregnancy. Don't do that.
Okay, thank you so much again for your explanation and for your advice. Perfect. And now we again have a two-part question. Okay, it will be a longer one, so let's get to it right now. I've had 10 IVF cycles, 8 cycles with my own eggs, resulting in 3 miscarriages, 2 with donor eggs, resulting in 0 pregnancy. Although my donor donated 5-6 times before giving each family twins. If I send you my reports, could you have a look at them? I've got DNA fragmentation on my husband's sperm, which results are very good. My BMI is 19.5. We've done genetic testing and we are compatible. I've had 2 laparoscopies and 2 hysteroscopies. I had polycystic ovaries but took metformin. Had fibroids which were much bigger than ultrasounds showed behind the uterine wall, but doctors said that should not affect my pregnancy because they are behind the wall. If I send you my reports, can you have a look at them?
Yes, I can, because you are most probably one of those patients that, being difficult, can have a chance to reach your dream only if you have a different point of view. So I will do this with pleasure. Any picture, any image, or any video related to your surgery could be very useful.
Excellent. Thank you so much once again for that. And let's get to the next question. Is longer stimulation for PCOS patients is beneficial?
I'm not able to answer this question because I don't know if for longer you mean long protocol with long agonist protocol, or if you intend as longer, more days with gonadotropins. Maybe if you can clarify this for me, I will be able to answer properly. Okay, you mean more days of stimulation. If you do, as we were discussing before, more days of stimulation, that means that you are injecting less unit of gonadotropins. You will take lower risk of hyperstimulation, and you will probably select less follicles. So in principle, I'm not against. I also would like to remind you that not many clinicians use it, but data, I mean, not only our own data, but data in the literature show that the original protocol, the protocol for IVF that was published almost 40 years ago in Science by the Australian group where I was working, was recommending a little bit of clomiphene, so 2 capsules per day for 5 days, to which you can add a little bit of gonadotropins. Little bit means 150 units every 2 days, so not even all days. And this works very nicely for PCO patients. So of course, it has to be done under strict control. And as you know better than me, PCO patients, they can react opposite one to the other. But this is a protocol that for some reason, very few clinicians remember to use. It could be an opportunity, a possibility. You should discuss with your doctor.
Okay, thank you so much once again for your answer to that. And so what do you mean by priming protocols?
Okay, this is a protocol that we have generated. It has been published, and the concept is quite simple. We are talking about poor responder patient now, according to the so-called Bologna criteria. That is a paper that has been published in 2011 and now is followed all around the world. It has more than 1,500 citations. So Bologna criteria are the criteria that everybody uses in UK, in Spain, in any country, in the United States. So we define poor responders according to Bologna criteria. So maximum 3 eggs, AMH very low, and the usual stuff. There is a category of poor responder patients that actually they do not respond despite the amount of gonadotropins that you give, because the FSH receptor are not prepared. So what we do is we give to the patients long analog, GnRH analog, let's say decapeptyl, for instance, a long-acting. Before starting stimulation, we give to these patients pure LH, recombinant LH, for 1 week or 10 days, with the aim to activate the FSH receptor. And then we start the stimulation protocol. So we stop LH today, that has been given for 10 days, and then we start with FSH, with the routine protocol. And what we have found is that this system, of course, not in all poor responders, but in many poor responders, mainly if they are young, they actually have not cancelled cycles, have a decent number of ovocytes, that means not only 1, but 3, 4, 5. The embryos look good. If you are able to transfer them, the pregnancy rate is acceptable. It's not like a normal responder, but is acceptable. You can find this data in the literature if you wish. Otherwise, you just let me know. I can send you this randomized study that has been done by our group. So the concept is you are a poor responder because your ovaries have a resistance to the FSH that we inject to you. Okay, let's have 10 days before, for 10 days, LH. So your receptors will be not surprised of the LH that we inject, but they are, in bracket, prepared.
Okay, perfect. Thank you so much again for your advice. You're explaining this all the details to us as well. And now let's get to the next question we have. Dear Dr. Gianaroli, thank you very much for the comprehensive analysis. I would like to ask you regarding appropriate stimulation protocols in POR, mite stimulation, or GnRH, gonadotropin stimulation.
Okay. We start with a mild stimulation first, and using clomiphene, that I was mentioning before. Clomiphene is a very old and very rough instrument that we as clinicians have in our hands, but sometimes it's better than pushing with an enormous amount of gonadotropin since the beginning of the cycle for the poor responders. So we start with the protocol I mentioned to you before, and if we fail, I'm not meaning by failing not pregnancy, but if we fail in terms of not having enough ovocytes to produce enough embryos to have at least an embryo transfer. So if we fail to get an embryo transfer, then we move to the protocol I mentioned to you that is we called priming protocol. So first clomiphene plus gonadotropins, and then we go for the priming protocol.
Excellent. Thank you so much once again. There are like 3 questions left, so we will be slowly finishing. However, if you have any questions left, this will be like a final call for them. So just go ahead and type them in the chat section. And the question is, my clinic has egg donation budget program where they offer 12 frozen oocytes or standard egg donation with fresh cycle. Is there any difference in results between fresh versus frozen oocytes?
Okay, if you mean difference in terms of results as pregnancy or delivery, the concept is probably like this, assuming, of course, that all the lab is working perfectly. To reach the same results, you need more frozen oocytes than fresh oocytes. So, if the donation program of your center is giving you 12 eggs that are frozen, or opposite to this, oocytes, and there are 12 fresh oocytes, you should go for 12 fresh oocytes. But if the program is reversed, so you say, what I would like to have is to have 3 blastocysts, to have 3 attempts. Then it's up to the center to provide 3 blastocysts. Doesn't matter if this needs 5, 6, or 8 fresh oocytes, or 12, 15, 20 frozen oocytes. Actually, that is not your problem. What you want as a patient that is waiting to receive an embryo to have the possibility to give rise to a full-term pregnancy is a blastocyst. Since you need oocyte donation, you should not be worried about the number of oocytes coming from the center. It's up to the center to find the great donor, to have the best vitrification program of oocytes, if they want to save oocytes to reach the scope of having 1, 2, or 3 blastocysts. So you should reverse the concept. You want a baby? To have a baby, you need to have a blastocyst in your womb. So you are looking for 1 blastocyst, or 2 or 3, according to the number of attempts that you want to do. The rest is a problem of the center. I don't know if it was clear enough.
Thank you so much. I believe it was. Well, if you would like to add anything, just go ahead, of course. Okay, and let's get to the next question. Thank you for a lovely talk. What is your opinion on the use of new approaches such as PRP or stem cells intra-ovarian infusion for ovarian insufficiency?
Okay, you're right in asking me what is my opinion. So, being my opinion, maybe can clash with other opinion of other colleagues. In 2022, no, in 2021 actually, next year, it will be 40 years that I'm doing IVF and related technique, having started in Australia. I'm saying this because along these almost 40 years, I went through plenty of frustration, plenty of excitement, every time that a new drug was coming out, every time that a new technique was coming out, every time that a new instrument was coming out. And I always heard by the deep of my heart and also by my colleague that that would be the real solution for all the patients. And we are now coming back to the concept of personalized medicine. The basket of infertile patients is plenty of completely different individuals. So we cannot expect that one technique, then one procedure, then one drug, that one instrument would solve the problem for everybody. So when we are talking about PRP or stem cells, we need desperately to look into those small categories of patients that could benefit of it. Furthermore, once that we have identified these subcategories, we desperately need to prove that they are, first, safe, secondly, efficient. Until we don't have these two pieces of information, I would recommend anybody not to have an opinion on this. So we need science first, and to reduce the risk to do treatments that are not necessary or not helpful to patients, we need first to identify those subcategories of individuals that could benefit. For instance, not all the poor responder or not all the patients that have an ovarian insufficiency or not all the patients that are older than 40 for sure would benefit of stem cells. Because if in that ovaries there is no substrate, you can inject any stem cell you want, but you never get anything out for that. So let's first select the patient that could benefit and do properly work, even if with a small trial, and then allocate, if it works, this technique to the right group of patients.
Okay, perfect. Thank you so much again for your opinion and all the details as well. And now, is there a difference in better quality eggs between choosing donor in her early 20s or late 30s?
Well, late 30 give you a higher risk of having chromosomal abnormalities, including, for instance, trisomy 21. If you think that actually you were asking me late 20s or early 30s, that would be most appropriate also because in many countries, including, for instance, Italy, oocyte cannot be donated by patients over 35. So we have restricted area. Anyway, if we have a range of 25, 22, up to 34, 35, okay, yes. Okay, so we agree. So we say between 28 and 34, 35. Okay, I ask you a question. Do you think that you have better possibilities to get pregnant if you have oocytes from 28 years old that never have done oocyte donation, never got pregnant, and she will donate to you 8, 7, 10 eggs? Or do you prefer to receive 3 oocytes from a 34 years old patient that has underwent an IVF cycle because of husband problems, and it has delivered twins with the other 4 oocytes that she had inseminated? So she had 7 eggs, 4 have been inseminated, 3 frozen. Those 4 eggs came out with twins as the first transfer. Which one would you prefer? The 3 eggs donated from the 34-year-old woman, or the 10 eggs from the 28-year-old woman that have never been proven to be fertile? I'm saying this because age, as we have discussed before, is not the only real market marker, of fertility. And we should always remember this.
Perfect. Thank you so much once again for your explanation. And well, I believe it definitely helped. Okay, and it looks like it will be our last question for tonight. So let's have a look at it. 12 frozen oocytes and 1 blastocyst guarantee, which is cheaper, or full price standard egg donation with as many eggs as the donor will produce with first transfer to be fresh transfer, which means it will be more expensive option. What do you think about that? Which one?
Yeah, since is is a double offer, I'm making some calculations. So 12 frozen and 1 blastocyst guarantee, that is cheaper, or full price standard egg donation with as many eggs as the donor will produce with 1 transfer to be fresh. Okay, of course, this has to be balanced with the expenses. If the cost would not exceed 20%, I would go for the fresh one. If the cost would exceed 20%, I would go for the frozen oocytes. As far as from those 12 frozen eggs, if you get more than 1 blastocyst, that you should get more than 1 blastocyst. The second or the third blastocyst should also be negotiated in terms of price. Be aware that if you need 12 frozen oocytes from a young woman to get only 1 blastocyst, either the donor has not been selected carefully, either the quality of the whole system is not completely optimal. From a young lady, from 12 frozen oocytes, you should expect to have 2 or 3 blastocysts.
Okay, thank you so much again for that. And in the meantime, we just have another question. Just let me go to it. Once again, sorry about that. I just need to find it. Yes, here it is. We have a chart together. Is worth to have genetic tests on our first IVF attempt, PCOS, only infertility reason?
This is a good question because, again, I find a lot of my colleagues that disagree with me. So, once again, it's possible that my opinion do not reflect the concept of all the other clinicians. We have a certain amount of patients that varies between 3 to 5%. That seems small, but actually is 1 out of 20, including the couple, of course, 1 out of 30, that has some chromosomal abnormalities that could affect the implantation, could affect the results of IVF. The question I make to myself is, and I make to the patient, is always the same. In Italy, at least in Italy, chromosomal analysis, it costs around 100 euros and it lasts forever. I mean, it's like to have the blood group, will not change in your life and it lasts forever. I'm not advocating definitely to do all these things to everybody, but I would like to have 1 dinner less, 1 new jumper less, but having done this exam before the beginning of all my infertility treatment. And the reason is very simple. If after 2, 3, 4, 5 failed IVF or ICSI, somebody suggests me to do a chromosomal analysis and it's come out that I am one of those 1 in 30, 1 in 50, doesn't matter, 1 in 100 that has a problem, that has an explanation why what I have done could not be successful, and there's an explanation why it was not successful, what I'm going to do? I'm going to strangle my clinician, I'm going to strangle myself. So 100 euro, one blood sample, it lasts for all your life. I would be in favor. Because, and this is the last point I like to make, when you say PCOS only infertility reason, it's wrong. It could be the only infertility reason. How do you know that your husband has not a chromosomal rearrangement, or yourself have not a chromosomal rearrangement? Maybe a thin piece of chromosome that doesn't change at all your life. It makes you perfectly safe, but it reduces the quality of your oocytes. How do you know?
Okay, thank you so much once again. That was, I believe, our last question. So huge thank you, Dr. Gianaroli, for joining our initiative, Stronger Together initiative, for being with us, for staying with us, even though we had some technical issues. We have managed, everything worked. So it's a pleasure to be able to be with you here as well, and just find out so many very detailed answers and information for sure. And well, I can only say that there are some patients that would like to thank you as well. So I guess you should definitely see it. There are some thank yous right here. For example, let me show you this. Thank you for a fantastic session. Great information. Personalized treatment sounds perfect. Great presentation. Thank you. There are more of those. We are happy that that was useful. And there's another one. Doctor, thank you so much for your full attention and patience to all questions and very detailed answered. Agreed. Definitely agreed with this. And well, wonderful information. Thank you. Thank you so much.
And I'm going mm, to apply the personalized treatment to myself, increasing my BMI with a nice dish of pasta now.
Okay, excellent. Sounds perfect for sure. Thank you so much again for joining us, everyone. Thank you for staying with us, even though you needed to wait. Thank you. It has been, as I mentioned, pleasure, and I am very happy that it all worked. And well, have a lovely evening. Okay. And again, thank you. And of course, just wanted to remind everyone that we will be back here on Monday at 6 p.m. UK time and then at 8 p.m. UK time. So there are plenty more events coming. So stay tuned. You can visit our website, myivfanswers.com, and that way you will be up to date with all of those events. And of course, this has been recorded, so you will have a chance to watch it once again. And well, that would be it for tonight. Have a lovely weekend as well. Thank you all. Thank you once again, Dr. Gianaroli, and have a lovely, lovely evening. Bye.
Bye bye.
Bye.